So in endocrinology, I said the portion of a brain which control the release of hormone is hypothalamus, and it is very closely anatomically as well physiologically. The pituitary gland is very close, a very small gland, but very important gland in endocrinology. It is very close to hypothalamus anatomically as well as physiologically. That is what I said. And then this anterior pituitary, pituitary gland is divided into two lobes, anterior pituitary and posterior. Okay, there is a lateral lobe, okay, also, and melanoid releasing factor is released from there, but anterior and posterior is there, and this posterior pituitary is extension of hypothalamus. That is what we said in last class. And this posterior pituitary gland releases oxytocin and antidiuretic hormone, which directly act on the organ and produces the response, while this anterior pituitary this produces various hormones. Okay, most of them they act through the gland, and prolactin.
Stick around, subscribe, hit that notification bell.
Okay, it act directly on the organ. That is what we said last time. So last time we discussed what is hormone. Hormone is a substance which is released from specialized cell and enter into the circulation and act on a gland or tissues. Okay, so we said, and they are the gland are ductless, so that is why they release the hormones into the circulation. And these hormones, they have very intense action, and they regulate body function as well as maintain the body homeostasis. So in pharmacology, we study hormone because these hormones are used in replacement therapy. When there is deficiency, we give these preparation, the hormonal preparation from outside. Sometimes it is used as diagnostic tool, and various in various disorders, these hormonal preparations are also used. Okay, so we classified according to the chemical nature, and according to the gland we will be discussing chapter wise. That is what we said. And hypothalamus and pituitary, we talked about that, the anterior lobe and the posterior lobe, which is the extension of hypothalamus. So that is why it is said neurohypophysis. Okay, and otherwise this anterior pituitary hormone release are regulated by the hypothalamus, and generally this is regulated by releasing hormone and release inhibitory hormone. Okay, when we want more hormone, then releasing hormone come to the picture, and when we want to stop that release, the releasing. And this anterior pituitary gland with various specialized cell, they release the hormone which act on target gland. Mostly they are target gland, and this hormone also send a negative feedback to the hypothalamus. Okay, which also control the release of the hormones from hypothalamus. And in the target gland, when they are activated with this anterior pituitary hormones, then they release hormones which produces the effect. Okay, and this hormone also send the negative feedback mechanism to anterior pituitary and hypothalamus to check the release of hormones from both the glands. And these are the list of hormones which are released by hypothalamus, we discussed in last lecture. And from pituitary gland, the anterior pituitary lobe releases six hormones. Okay, when we consider follicle stimulating hormone and luteinizing hormone separately, we say six hormones. So these two, and thyrotropin, corticotropin, prolactin, and growth hormone. And out of these, we will be discussing today in today's class. We will be talking about growth hormone, prolactin, and maybe in other class we will be talking about follicular stimulating hormone. Lobe releases melanocyte stimulating hormone, and posterior lobe vasopressin and oxytocin. Vasopressin has already been discussed in the renal system, and oxytocin we will talk in the drug acting on uterus. Okay, am I audible to you all?
Yes, sir.
Okay, because there is some message popping out and then telling poor network. Okay, so I think in last class we stopped here by explaining this slide, isn't it? Yes?
Yes, sir.
Okay. So in this slide, what we said that hypothalamus releases the hormone into the circulation. So from blood, these hormones are released. Okay, the hormone which are released by hypothalamus are GnRH, okay, TRH, CRH, okay, and you know the full form, isn't it? So these all. So out of these, the therapeutically important is GnRH. So today we will be talking about this hormone, okay, among the hormone released by hypothalamus, okay, and then these hormone will stimulate the particular cells and releases the particular hormone. That is when GnRH will stimulate the particular cell in anterior pituitary lobe, and that causes release of FSH and LH. Okay, and they act on the organs. And similarly, TRH will cause a release of TSH, thyroid stimulating hormone, and that will act on thyroid gland and releases thyroxine. Similarly, the CRH will stimulate to release ACTH from anterior pituitary gland, which act on this cortex of suprarenal gland, and which releases cortisol. This is also a hormone. And growth hormone, okay, growth hormone releasing hormone, okay, it act in particular cell and releases growth hormone, which act on the liver and promote the growth. And prolactin, okay, it anterior pituitary lobe releases prolactin, and that directly act on the organ. So all these are acting on a gland and producing the axon, while prolactin is directly acting on the organ. Similarly, posterior pituitary hormones, ADH and oxytocin, are also released from here and then directly act on the organ. Okay, so these three are directly acting, while these all act on a gland and then or on liver, and then produces, okay, hormones, and that will act and produces the response, while prolactin, ADH and oxytocin, they directly produce the response or effect. Okay, so here we discussed last time. Now let us start. So in today's class, let us discuss the hormone released from hypothalamus. Okay, hypothalamic regulatory hormones, and I have already said that the therapeutically most important is gonadotropin releasing hormone. Okay, we have a preparation of agonist and antagonist, so we will discuss this among the hypothalamus. Then we will go to the hormones released from anterior pituitary gland. Okay, and this is what is included in your syllabus. Your syllabus says that we have to talk about these. Okay, So that is why today we will discuss on this. So gonadotropin releasing hormone, GnRH. This is a releasing hormone released from hypothalamus, and hypothalamus secrete this hormone in a pulsatile manner. Okay, in a pulsatile, so that stimulate the gonadotrop cells in anterior pituitary gland, and this anterior pituitary gland which synthesize and release LH and FSH. Okay, now see, when it is given in a pulsatile way, when it is or naturally it is released in a pulsatile way, on pulsatile it stimulates the gonadotrop cells which is present in anterior pituitary, and that releases LH and FSH. The action and other thing about LH and FSH we will talk as a hormone released by anterior pituitary gland. Okay, here we are talking only gonadotropin releasing hormone. Okay, GnRH, because this is the hormone which is released by hypothalamus. Okay, so we will concentrate on this. The detail of LH and FSH we will cover in next class, I hope. Okay, so this gonadotropin releasing hormone, we have the synthetic preparation. Okay, human gonadotropin releasing hormone, which is also the other name for that is gonadolin, and it is short acting. T half is 4 to 8 minutes. It is given IV or subcutaneously, and generally it is not very commonly used one. It could be used to test the function of pituitary gonadal axis. Okay, pituitary, I have already said, when pituitary hormones, they are released, they act on the gland, gonadal gland, from where again the hormones are released. Okay, so that is what the axis is said to be, pituitary gonadal axis. Okay, so that sequence of the glands, okay, are said to be the axis. So here it is used whether that axis is working properly or not. To test only we use it. Okay, and now let us talk about GnRH analog. Analog means these are the preparation, these are the medicine which act like GnRH, okay, gonadotropin releasing hormone. Okay, and leuprolide, okay, this is one example, and next in neferlin, okay, so lean, there are other leans also, but this is very peculiar, neferlin, because it is administered by nasal spray, while other they are given by injectable route. Okay, so that is why from MCQs also it is important, but all these are the analog. That means they mimic the action, or they produce the action similar to that of GnRH. So they mimic the action of GnRH, or you can say it produces the same action as that of GnRH. Okay, but the natural, compared to natural GnRH, they are very potent, almost 15 to 150 times more potent, and it has a long half-life. Okay, while when you see the previous one, the half-life, this is the synthetic human GnRH, where the T half is just very short, 4 to 8 minutes. Okay, and while this is very long acting, 2 to 6 hours, and it is potent also. So that is why this is used therapeutically. This is more preferred therapeutically than the hormonal, the synthetic human GnRH. Okay, so this preparation is used therapeutically. And now see, in previous slide I have said that in naturally the GnRH is released pulsatile way, so that will stimulate the gonadotrop, okay, in anterior pituitary gland. But remember, if it is released for a long period, continuously for long period of time, then what happens? It will send the negative feedback mechanism. Okay, and then it will inhibit the action. It will produce the opposite action. Okay, so analog, they are when given in a pulsatile way. Okay, in a pulse. Okay, IV administration every 1 to 4 hours. That means you give, and then there was a gap, no administration was done, and after some time again you are administrating. So that is why it is a pulsatile way of administration. When you give pulsatile way, then it will stimulate the anterior pituitary gland. Okay, it stimulate if you give in a pulsatile way. Okay, so this will stimulate the anterior pituitary gland to release FSH and LH. Okay, and that will cause ovulation. Okay, while if you give in a continuous way, okay, no stoppage, just continuously if you give, okay, in an IV infusion form or in a depot formulation, then it will produce opposite action, that is inhibit the GnRH release and suppress the gonadal function, so suppress the ovulation. So see, same preparation, when you are giving in a pulsatile way, you are stimulating, and same when you are giving in a continuous, then it produces the opposite action, or it inhibit the action of GnRH. So this is very important. So same drug or preparation, how you have given, as per that you will get the result. Okay, and this is what somewhere related to the negative feedback mechanism. Okay, so now where are these preparation, the GnRH analog are used? They are used for stimulation. For stimulation we use this. When you want a stimulation, you have to give in a pulsatile manner. Okay, when you give in a pulsatile way, then you can treat infertility both in male and female. You can treat the infertility. Okay, and for diagnosis of LH responsiveness also. Okay, you can do. But if you give in the sustained, prolonged, okay, continuous form, okay, in a depot preparation or an infusion form, then what will happen? It will have the opposite action. It won't stimulate, rather it will depress. So that is why it is used in prostatic carcinoma, okay, the cancer of prostate, uterine fibroid, endometriosis, and even to suppress the puberty, early puberty. Okay, precocious puberty, it could be prevented. Similarly, polycystic ovarian disease, and sometimes now see this GnRH analog is used to have a controlled ovarian hyperstimulation to get a very good ova. Sometimes we generally very in a modulated way, controlled way, we use these GnRH preparation and other formulation, so that we get very good ova for in vitro fertilization. In vitro means what we say, test tube babies. Okay, so in vitro reproduction, sometimes these are used. Okay, so you can now see with this you can stimulate also, you can depress also sometime. Okay, when you want to suppress, then it could be given. Okay, so adverse effect of these preparation is headache, lightheadedness, nausea, hot flushes, sweating. Okay, and there will be diminished libido. Okay, vaginal dryness. So again, the side effects also somewhere depend on how you give these analogs. Now, similarly, we have GnRH antagonist, that means blocking action. Okay, even with agonist also you have some antagonistic action by giving continuous way, but we have some drugs, okay, like ganirelix, these all relics, cetrorelix, digarelix, etc. They are antagonist. They act opposite of that of GnRH. So they competitively block the GnRH receptor. Okay, GnRH receptor at anterior pituitary gland, and it has a fast action compared to agonist. Like I have said, the agonist also, when you use for a long period of time, then there will be suppressant antagonist, and the agonist is that the action is fast. Okay, so it inhibits the FSH and LH release. Ganirelix and cetrorelix are approved for use in controlled ovarian hyperstimulation procedure in vitro fertilization, that is in test tube babies. Digarelix is approved for man with advanced prostate cancer. Okay, so now see this suppressant or antagonistic action. These are the action or these are the conditions where we use GnRH as an agonistic form. So these all could be achieved by using the antagonist. This antagonist also. So antagonist will produce little bit faster action. Okay, so the same use is there. It has a low risk of ovarian hyperstimulation syndrome with compared to agonist. So that is why it is sometimes preferred. Now this is all about the GnRH, its agonist or the preparation. We talked about the natural synthetic human GnRH, and we talked about the analogs also. Analogs means which act as a agonist or say which produces the similar action of GnRH, and we talked about the antagonist, its preparations and the side effects. And this is this almost cover the syllabus of your level, that is third semester syllabus is completed or it is covered. So this is sufficient for you. Okay, now let us talk about the hormones which are released by anterior pituitary hormone, and we will be more concentrating. Okay, as per the syllabus, we will be talking about growth hormone and its analog. We will be talking about growth hormone inhibitors, where they are used, what are the side effects, and we will be talking in detail about the prolactin analog and inhibitors, because this we won't be discussing anywhere else. And then we will be talking about gonadotropin preparation. So gonadotropin releasing hormone we have finished as a hormone released by hypothalamus. But once that GnRH will come and act on an anterior pituitary lobe, then the gonadotropins are released, that is LH and FSH. What are their action uses, we will be talking here. Okay, so growth hormone, prolactin and gonadotropin, this will be taught in detail in anterior pituitary. There are other hormone also, ACTH, TSH, which is released by anterior pituitary hormone, but that will be discussed separately in the respective chapter. Like thyroid stimulating hormone, we will talk that thyroid stimulating hormone in thyroid hormone, while ACTH we will discuss in corticosteroid. Okay, so now anterior pituitary hormone. Now let us talk about the growth hormone. This is now growth hormone. Okay, this is a hormone released from anterior pituitary lobe, and we say it as a somatotropin. Okay, somatotropin, because I'm emphasizing on this. Somatotropin means growth hormone. Okay, somatostatin, stat means static. Okay, like checking or stopping. Somatostatin, that means the drug which stop the somatotropin, that is antagonist, it's somatostatin. Sometimes most of the time our student get confused with somatotropin and somatostatin. Okay, so don't get confused. Somatostatin here, it checks the release of growth hormone. Okay, so it checks the growth, it is antagonist, while somatotropin is the growth hormone, or you can say agonist. Okay, so this growth hormone, it is a polypeptide hormone released from anterior pituitary gland. It's how this hormone is regulated. It is regulated by hypothalamic hormones. What are they? GHRH, growth hormone releasing hormone, and somatostatin. Okay, somatostatin, it is released from hypothalamus, but since it is related with the growth hormone, so we will be discussing here the somatostatin and its analog in detail over here. Okay, somatostatin. And somatostatin, it is not only released by the hypothalamus, there from other part of our body also somatostatin is released, and they have the different action. So we will be talking about that. Okay, so it is the growth hormone, how it is regulated is it is regulated by hypothalamus. Hypothalamus, when want to release more growth hormone, will release GHRH, that is growth hormone releasing hormone, then more growth hormone will be released. And if hypothalamus releases somatostatin, then anterior pituitary gland will stop the release of growth hormone. So this is how it is checked. Okay, increase release caused by GHRH, and stopping of the release is done by somatostatin. Okay, so now this growth hormone, it controls, actually growth hormone is responsible, or it controls the growth of all our organ. Okay, body organ except brain and eye. Except brain and eye, all organ growth is controlled or dependent on growth hormone. Okay, while brain and eye, it is not so. That is what, except this other are. And this growth hormone, it produces action. How does it produce action? It produces action directly also, and also this growth hormone will go and act on liver, and from liver it cause release of insulin like growth factors, especially 1 and 2. But for mediating the response or the effect of growth hormone, IGF, that is insulin like growth factor 1, is more important. Okay, so this growth hormone produces action directly as well as through elaborating the insulin like growth factor. Okay, so this in detail will be taught in physiology. So the thing which is required by pharmacology, we are just discussing. Okay, got it?
Yes, sir.
Roll number 79. Who is roll number 79?
Yes, sir.
Okay. So growth hormone affect the growth of which organ?
Sir, somatic growth. All except eye and brain.
Except?
All except eye and brain.
Okay, good. So now how this growth hormone is regulated? The hypothalamus, if it want to release want to release more growth hormone, then it will release growth hormone releasing hormone. So when growth hormone releasing hormone is released, then anterior pituitary will release the growth hormone. Okay, and hypothalamus check this release of growth hormone by somatostatin. So these two balance. Okay, So if somatostatin action is more, there won't be release of growth hormone. If the activity of this is more, then there will be more release of growth hormone. Okay, so this is what. And anterior pituitary gland that will release the growth hormone. Okay, this growth hormone is released by this. Okay, and this growth hormone will act on the target tissue, that is liver, and it also send the negative feedback to hypothalamus. Says growth hormone, when it is released, then it says hypothalamus to stop the releasing growth. Okay, releasing the growth hormone, releasing hormone. So it will, growth hormones will say to hypothalamus, don't release growth hormone, releasing hormone. I am there now, I am sufficient, I will take care of growth of this, isn't it? So this growth hormone will act on liver, as well as what, it will send the negative feedback mechanism. And from liver, the insulin like growth factor will be released, and that will produce the effects in all the organ except eye and brain. And this IGF also send the negative feedback to anterior pituitary to stop the growth, and similarly this will also send the impulse, negative feedback to hypothalamus to inhibit the release of growth hormone, releasing hormone. Okay, this is how the growth hormone is release is checked, or it is regulated or balanced in our body. Okay. So what are the actions of growth hormone? So growth hormone produces action through IGF, okay, insulin like growth factor, which is the indirect. Now what it does indirectly is it increase uptake of amino acid by tissue and synthesize them into protein. So it will uptake the amino acid and will be utilized for protein synthesis, and when there will be protein, it will, the growth will be promoted. So it has an anabolic effect on protein. Okay, and similarly it promote utilization of fat and spares the carbohydrate. Okay, so utilize the fat, okay, for the anabolic activities. It reduces the glucose uptake by muscle and increase glucose from liver. So glucose will not be utilized by muscle, and output from the liver, the glucose output from the liver will be more. So what will happen to the blood sugar level, blood glucose level? Roll number 80. Roll number 80. Are you there? No? 81.
Yes, sir.
Okay, 81. What will happen to blood glucose level?
Sorry, sir.
Yes, muscle will not take the glucose. Okay, number one.
Yes, yes.
And liver will release more glucose. So what will happen to the glucose in blood?
So increase blood glucose level increase.
Yes, blood glucose level increases with growth hormone. Okay, so that is what you remember. When blood glucose level will increase, so at this slide, please remember glucose level is increased. Next slide, we will add some more information. Okay.
Okay.
So it also, growth hormone also has a direct action. Okay, it not only act through the liver, but it also has direct action, and indirect it promote lipolysis. It the breakdown of the fat in adipose tissue is promoted. So breaking down, fatty acids will be formed. Promote gluconeogenesis. That means formation of a glucose from non-carbohydrate source like fatty acid, which is released from lipolysis, will be utilized for gluconeogenesis, and glycogenolysis in liver. So promote glycogenolysis. So the formation of glucose will be promoted, and glycogenolysis. Glycogen will be broken down, made to sugar. So that will also happen, and decrease glucose utilization by the muscle. So muscle will utilize less. So all these things will cause increase blood sugar level, increase, okay, blood sugar. Okay, so increased plasma glucose. So when this plasma, so plasma glucose or blood glucose will increase, isn't it, with this direct action as well as indirect action. So when there is increased blood glucose level, it will stimulate insulin. Insulin will be stimulated to the pancreas, will be stimulated to release insulin. So stimulate insulin secretion. So pancreas will be stimulated to release the insulin. And if the person is normal, okay, normal, then insulin is released by the pancreas, because pancreas has sufficient amount of insulin. It will be released, and this whatever increased blood glucose level is there, so insulin will try to decrease the blood glucose level, and there will be ultimately there will be no change in blood glucose concentration. So ultimately, initially it will rise, and then insulin will be released, and insulin will decrease the blood glucose level, so there will be no change in blood glucose concentration. But if same thing happen in a diabetic patient means the patient pancreas is not able to produce sufficient amount of insulin. Okay, so blood glucose level will increase, and that blood glucose will stimulate the pancreas to release more insulin. But since the patient is diabetic, so pancreas will not be able to release sufficient amount of insulin. The insulin will not sufficient to decrease the blood sugar level. So that is why the blood glucose level will increase dramatically. Okay, it won't decrease. Are you getting me?
Yes, sir.
82, roll number 82.
Yes, sir.
Okay, what I said, can you just elaborate the thing?
Sir, growth hormone inhibits muscle uptake
So
of.
growth hormone, what does it do? The glucose level, blood glucose level, what does it do? The growth hormone increase or decrease blood glucose level?
Increases, but in response
Yes.
to the pancreas
Yes.
insulin,
Yes.
it
Okay.
often goes back to the previous level.
Now see what happened. Growth hormone will increase blood glucose. That is sure. Okay, it will increase blood glucose. Now, when blood glucose in our body, when blood glucose level increases, it will stimulate insulin secretion. The pancreas will be stimulated to release the insulin. Okay, so that will cause insulin to release. But if the person is normal, able to release the sufficient amount of insulin, then what will happen? The glucose which has been increased by growth hormone will be decreased by insulin, and then the level will become normal. Are you getting me? But if the patient is diabetic, then what happens? It will not be able to produce the insulin. So that insulin will not be sufficient, and the blood glucose will not decrease. The blood glucose which has been increased by growth hormone will not decrease. Okay, got it?
Yes, sir.
Roll number 75.
Yes, sir.
Yes, can you try to explain what I mean to say here?
Sir, the growth hormone cause increase in blood glucose level.
Yes,
So
correct.
if there is normal person, then the insulin production is normal, so which decreases the blood glucose level. But if there is
Yes.
diabetic person, there is less or insufficient amount of insulin, which cause increased blood glucose level, and which
Yeah.
also aggravated by gluconeogenesis.
Okay, so that is why in diabetic there will be dramatically increase in blood sugar level. So this is important in MCQ. You will get some questions from this. Okay. Now deficiency. What will happen if there is deficiency of growth hormone? If there is deficiency during the childhood, it result pituitary dwarfism. Okay, dwarfism is there, but here what happens? The pituitary dwarfism will be there. What does that mean? Is the growth is retarded, but not associated with mental impairment, because this growth hormone doesn't affect the brain, isn't it? Development of a brain. So brain development will be okay. Only the body development will be affected. So the size of the human will become smaller, but mentally it will be sharp. But if there is deficiency of thyroid hormone also, then there will be mental impairment. Okay. So pituitary dwarfism, if the mental development is okay, only the body structure is smaller, then we say pituitary dwarfism. Okay, so in that case, you can use growth hormone. So for the treatment, we have a recombinant human growth hormone, that recombinant DNA technology. From there, we have prepared the growth hormone, and that growth hormone is said somatropin. Okay, it is not somatostatin. Okay, remember somatropin. It is given subcutaneously 30 to 40 microgram per kg, and it is given daily till the age of 20 years. Okay, but remember, when you use this growth hormone, recombinant human growth hormone, you have to be sure that the growth is not there. The this retardation of growth hormone, it is not deficiency of other. If it is deficiency of growth hormone, then supplement it. So before starting, you have to be sure, it has to be proven that the retardation is due to deficiency of growth hormone. Okay, and it should be given before. Okay, before epiphyseal closure, the epiphyseal, the bone. Okay, epiphyseal closure, it has to be given before, not during or after the epiphyseal, because you won't see the effect of growth hormone after that. Okay, the growth will not be promoted, so it should be before that. Okay, so this is in case of deficiency of growth hormone. Then other uses of this recombinant human growth hormone, somatropin, it could be used in Turner syndrome. So here the Turner syndrome is generally, it is a genetic disorder seen in the female. Okay, and I think in anatomy they will discuss in detail about this Turner syndrome. Here what we do is, we, to promote the growth, the physical growth, we give recombinant human growth hormone, this one, and with properly timed androgen and estrogen therapy. Okay, because that is the sex hormones are also required. In that way we try to treat. Okay, this is a genetic disorder seen in female. In if someone having chronic renal failure, especially in children, and this chronic renal failure is causing suboptimal growth, okay, is inhibiting the growth of the children, then you can use growth hormone. And if there is growth hormone deficiency in adult also, it could be used. Okay, and AIDS. Okay, it's related muscle wasting and other catabolic stage, catabolic, because this growth hormone is an anabolic hormone, so we can use for this to prevent the wasting, muscle wasting. And similarly, the constitutional or idiopathic, short stature, the height is small, in that case we can use in children. Okay, the adverse effect of this is pain at the site of injection, lipodystrophy. Lipo means the fat, dystrophy, disbalance. Okay, the where you inject, there could be fat, mostly there will be lysis of a fat. Okay, so lipodystrophy, glucose intolerance, the glucose level will increase. If the person is not able to secrete sufficient amount of insulin, then the glucose intolerance will be there. In diabetic, there will be precipitation of diabetes mellitus. It may cause hypothyroidism and peripheral edema, and edema could be seen. It is due to salt and water retention in the body. Okay. Now, what will happen if there is excess growth hormone? If excess growth hormone is there in children, we say gigantism, and if it occurs in adult, we say acromegaly. Okay, acromegaly. So the growth will be very high. Okay, unexpectedly. Okay, more growth if there is. So that is what we say. And acromegaly is characterized by enlargement of many part of skeleton, okay, and coarse facial feature and wide hand and feet. Arthalgia, headache, excessive sweating are common in these the person suffering from acromegaly. Now here, generally in acromegaly, we see the tumor or adenomas in the pituitary adrenal, the pituitary anterior lobe of a pituitary gland. So if it is there, then we do the surgery and try to remove that. Okay, so surgical is the main therapy. But if there is a small adenoma, okay, then we can go with the radiation therapy. Okay, it could be primary. If it is the adenoma is small, we can do that, or if it is big, then we go for surgical excision, and after the surgery we can go with radiation. Or if the adenoma is smaller, then we use a drug like somatostatin and its analog. So this is what if there is an excess growth hormone. Now let us talk about somatostatin. Somatostatin, so it is a growth hormone inhibitor. Okay, in the previous slide, from the previous slide, I have been emphasizing on the somatostatin is an inhibitor. Okay, somatropin is different, somatostatin. Okay, so this somatostatin, it is 14 amino acid peptide. Okay, it has 14 amino acid peptide, and it is secreted by hypothalamus. I have already said it is secreted by hypothalamus. It controls the release of growth hormone from anterior lobe of pituitary gland. Not only that, it is also released by GIT, gastrointestinal tract, as well as pancreas. The delta cell of pancreas also release somatostatin. So somatostatin, it is not only localized in brain, it is not only released by hypothalamus in other portions. So that is why somatostatin have other actions also. Since it is released in GIT, there is some role of that pancreas, there is role. So that is why somatostatin we not only use as a growth hormone inhibitor, but for other purpose also. Okay, so this somatostatin inhibit release of growth hormone. Growth hormone, it causes inhibition of release of growth hormone. TSH release is inhibited. Thyroid stimulating hormone, prolactin from pituitary gland. Okay, glucagon, okay, from pancreas, glucagon and insulin from pancreas. So the this somatostatin released from pancreas, the action is to inhibit the release of glucagon and insulin. So that is why this somatostatin we will be talking in the insulin and diabetes mellitus also. Okay, so similarly, almost all GI secretions, including gastrin and HCl, are inhibited by somatostatin. The somatostatin which is released by GIT. So the somatostatin from GIT will inhibit the release of all GI secretions. Okay, and this somatostatin, they constrict the splenic, hepatic, and renal blood vessels. And these all somatostatin, they act on their own receptor, somatostatin receptor. Okay, so uses of somatostatin, where do we use is because now see, it constricts the blood vessels. So that is why when there is esophageal varices, very commonly used use of somatostatin is esophageal varices and bleeding peptic ulcer. PU means peptic ulcer because it decreases the GI mucosal blood flow. So that is in pancreatic, biliary and intestinal fistulae, it could be used. And to reduce the complication after the pancreatic surgery, it is used. It is adjuvant value in diabetic ketoacidosis. It is not a main drug, but it has adjuvant value because it decreases the glucagon and GH. Okay, that is growth hormone. Growth hormone also causes rise in blood sugar level. Okay, glucagon also increases blood sugar level. So it has adjuvant value. And it is also used in acromegaly. I have already said if the adenoma is smaller, then we can use somatostatin. But as such, somatostatin we don't prefer. Why? Because the important drawback with somatostatin is it has short duration of action. Just T half is 2 to 3 minutes. So that is why it is not used. For the same purpose, we will be using a longer acting somatostatin analog. What is that? The longer acting is this octreotide. In MTH, you will find that octreotide is some of the very commonly used, especially in ICU patient where there is esophageal varices. Okay, bleeding is there, especially in chronic alcoholic and other. So these all uses. Okay, here even though you can use somatostatin, but somatostatin is not preferred because of its short action. So for all these action, we have octreotide, which is a synthetic octreopeptide, which is more potent and longer acting than somatostatin. So that is why octreotide is preferred one. And it has very weak inhibitor of insulin secretion, so it doesn't affect the insulin secretion. Okay. And it is preferred over somatostatin for acromegaly, esophageal variceal bleeding, secretory diarrhea associated with carcinoid, AIDS, chemotherapy, and diabetes. Okay, so octreotide. So somatostatin analog we have discussed, and we said that this, even though it could be used in these conditions, but we don't prefer because of short action, short duration of action, and longer acting is octreotide, and we use octreotide over here. Okay. Similarly, so what are the side effects of octreotide? It causes abdominal cramp, nausea, vomiting, flatulence, etc., etc. And very importantly, if it is used for long period of time, it may cause gallstone. Okay. And hyperglycemia is infrequent, not very frequently, because its action on insulin is lesser. It causes vitamin B12 deficiency if it is used for long period of time. And similarly, the other newer analog is lanreotide. Okay, and this is further more longer acting than the octreotide. Okay, it is given intramuscularly, and intramuscular this act for 10 to 15 days. But in MTS till now, the most commonly used is octreotide. Okay, so very important from examination point of view also. Okay, octreotide. Now I think this will be our last slide for today's class. Pegvisomant. Okay, so this is growth hormone receptor antagonist, and it is used for treatment of acromegaly due to small pituitary adenomas. So this is a newer preparation, the antagonistic preparation. Okay, so which is commonly preferred in acromegaly. So this is all for today's class, and in next class we will finish the hormones of anterior pituitary hormones. Okay, next class means tomorrow 10 o'clock. If you have any question, you can ask. Yes? Any questions?